So I would like to welcome you to this special session of the ACC and the IHS. This session has become routine at our meeting and has always been of a very high academic standards. We appreciate the effort made by the guest speakers to be here with us in our meeting and in this session, and we thank you all for coming. The first speaker is going to be our co-chair, Dr. Williams, who is the president of the American College of Cardiology. And Dr. Williams is going to talk about somewhat controversial issues. The title of his talk is Tough Choices, Diet and Cardiovascular Disease, What is the Evidence? So please, Dr. Williams.
Thank you, Dr. Rozenman. I first want to express my thanks and gratitude to organizers and for the invitation and the fact that we could have this long-running series of ACC Israeli Heart Society meetings. We really appreciate the hospitality and everything that you guys have organized here. I do have a somewhat difficult task today, and I was taught long ago not to talk about politics and religion in public, and this is actually very similar to that. People feel very deeply about their diets, and so there's a lot of controversy, I'll just say, and it's also a very large growing area in terms of the scientific literature. So it's worth a review to try and see where I think we should go. During that nice introduction that Dr. Rozenman gave and my preliminary comments, at least in the United States, at least one American had a cardiac death, and this has been a major issue in the United States. It's been the #1 cause of death in the United States since 1918, when it was supplanted for 1 year by the Spanish flu. It was actually very good to see that the good news in the United States, which has been the reduction of heart disease. We've had about a 50% reduction in cardiovascular mortality over the last couple of decades. And we attribute it to a lot of different things. As an imager, I think that it's all due to nuclear cardiology. But most people would disagree with that. We've had a lot of improvements in medications and revascularization techniques that can help folks. But there has been some attention, more lately than over that 2-decade period, with prevention. I understand that from the talks yesterday that in Israel we've already been able to get cardiovascular disease down to #2, and that is tremendous. I'll have a couple comments on that later. Diet usually brings up the whole idea of weight, diabetes, cholesterol. And one of the things that we've really learned about cholesterol over the years is that we are able to lower cardiovascular mortality if we can lower cholesterol. Now, the question is that really because of effects on the cholesterol and the LDL cholesterol that you've seen here, this very famous lipidology slide, or does it have to do with other elements such as inflammation? Well, this became highlighted last month, and I did hear that this was not, this news did not go unheralded here in Israel, that we had every 5 years, there's a nutrition panel in the United States that gets together and does dietary recommendations. And the one a couple months ago actually made comments about coffee being good, fat being bad, red meat being bad, sugar being really bad, but that cholesterol was actually okay. And most of us were shocked to hear that. They were saying that cholesterol is not considered a nutrient of concern. And so when we actually dive into that, as anyone interested in the diet area would, this was their paragraph. Saying that the previous limit of 300 milligrams per day that they had recommended was going to go away, and that the 2015 guidelines would actually not bring that forward, and they base it on the ACC-AHA report, reference to here, and then a second reference, and I'd really just like to show that to you for a moment. This is actually from the slide set made by the American Heart Association and the ACC talking about dietary cholesterol and saying very clearly that there was insufficient evidence to determine whether lowering dietary cholesterol would actually have an effect on LDL-C cholesterol. And so there was no recommendation to free up taking in cholesterol, and that did not come from those guidelines. The other article, the Shin article shown here, was actually about eggs, specifically about eggs. And as most of you know, that's a very high source of cholesterol. Most folks are astounded to find out that when they eat 2 eggs, they're eating about 6 pork chops worth of cholesterol. And so it's in the United States, it's a kind of a big deal. As it turns out, the question is whether or not that dietary cholesterol from eggs would actually have an effect. And in looking at some very large cohorts, followed over a fair amount of time, but not the longest time, there was no correlation that they could find between ischemic heart disease and ischemic heart mortality or stroke. But one would have to actually take dietary studies out very, very long because we're hoping that our patients will live more than 5.8 to 20 years. And there were a couple of findings that they really highlighted in the review. One was that there was a 42% increase in the amount of diabetes that occurred in those who ate a lot of eggs, that is more than 1 per week, or one per day, versus those who ate less than 1 per week. And also, if you were a diabetic, that egg consumption resulted in almost a 70% increase in overall cardiovascular disease mortality. And so why is there so much controversy? If I were actually to defend those new guidelines, I would have probably used this study, a quote by the Fernandez group saying that it's highly variable. And that probably is the source of concern, is that everyone responds differently to a cholesterol challenge, and about 75% of the population has either a mild increase or no increase in plasma cholesterol. Not that that's a hard endpoint, because it certainly isn't. But there are so-called hyper-responders who, when they take in cholesterol, actually have a significant rise in LDL and HDL cholesterol. If you look at other data, which I think would have been good for the committee to do, there's a substantial amount of data that is observational, and this is one of them. One of the largest studies is the Nurses' Health Studies and the Competing Risks Analysis, where they actually look at a variety of things, everything from age to habits. And just highlighting this upper right-hand corner, the dietary cholesterol, which would be about 1/2 of 1 egg, actually had a 17% increase in mortality. And so there is enough data to suggest that cholesterol is something of concern, and hopefully future guidelines will take into account a more variety of data. Continuing on this subject of what happens to risk factors, because cholesterol is not the only thing that we're concerned about in cardiovascular disease. One study of interest was actually published by the Adventist Health group that actually has a sort of a religious bent toward more healthy diets, and they sort of divide their congregation, and this is many thousands of people followed over quite a long period of time, into the usual American diet called non-vegetarian. Semi-vegetarian would mean that they cut down the number of animal products. Pesco-vegetarian means that the major protein source would be fish and dairy. There's the lacto-ovo-vegetarians that actually don't eat any poultry or fish or red meat. And then there are the vegan people who actually eat no animal products. If you look at their original publication, they actually were able to find a sort of stair-step effect with these diets in terms of obesity, also in terms of diabetes and hypertension, with about a 75% to 80% reduction in diabetes and hypertension, which you think would play out over the next few decades as a decrease in cardiovascular events. And we'll talk about that in a bit. But sticking with, for a little bit with the subject of cholesterol and other risk factors, we've all heard about C-reactive protein and how somewhat independent of cholesterol it can be related to cardiac events. And one of the best studies that ever looked at the effect, at least acutely, of diet on lipids and C-reactive protein was actually the so-called portfolio diet, where they actually took a relatively low American Heart Association type of diet, low in dairy, low in saturated fat, did the same diet plus lovastatin, the original statin, and then actually ditched the statin and the dairy, et cetera, went on a vegan diet for 16 patients, and with viscous fibers and almonds. And I want to point out the almonds for a couple reasons. One is that the study ultimately was sort of derailed by the fact that it was supported by the California almond industry. And so it was thought to have more than a little bit of conflict of interest, even though it was published very widely. But also that there are loads of data accumulated over time that say that nuts, in all of its flavors and forms, is actually a great meat substitute. As it turns out, that portfolio diet was associated with a significant fall, relatively acutely, in LDL cholesterol, as well as C-reactive protein, and it actually matched the results that one could get on a healthy diet plus a statin. So you wonder why most folks haven't heard of the portfolio diet. Part of it was the almond issue, but part of it is the fact that, as I'll mention, when we talk about doing guidelines, we like to have studies that are large. And that is, I can't emphasize that more, that you'd like to have at least 50 observations in each group. And as you noticed, this was 16 patients in each group. It's interesting, makes a p-value. It's not going to make it into our guidelines other than maybe a footnote. One of the best ways of looking at improving risk factors was actually published not long ago by Dr. Dean Ornish, who's famous in the United States for reducing bad outcomes in cardiovascular disease. Again, the number of patients and observations was relatively small, but he had actually a couple of studies, one early and one 8 years later, with 1 and 5 year outcomes respectively. And some pretty remarkable angiographic data were obtained showing stenoses that sort of disappeared over time with a very restricted diet, being completely vegan. But the Ornish program does include a lot of other things that most of us as scientists maybe wouldn't pay as much attention to. Exercise, definitely, plant-based dieting, but also stress reduction. And nowadays we pay a little bit more attention to that because we understand that catecholamines and cortisol maybe go up in stress environments and result in cardiovascular events. If you look at their plaque regression data, though, it's pretty remarkable, just sort of blowing it up here, that percent diameter stenosis tended to progress in the control group, tended to regress in the treatment group, and so that gives us really a small amount of data. It's high-dose atorvastatin, high-dose rosuvastatin, Caldwell-Esselstyn's diet at the Cleveland Clinic, and Dean Ornish's data all pointed toward regression, but that's just about all that we have. Again, note that there were p-values here. They were quite significant, but the number of patients in each group, 6 and 7, not going to get into the guidelines. Let's move away from risk factors for a moment and talk about mortality. One of the best studies that looked at this recently in large quantities was actually the Adventist Health Study. Gary Fraser, going back to the data of his group. And it actually showed that if you took the vegetarian diet, particularly in men, you found about a 20 to 30% reduction in all-cause mortality, ischemic heart disease, cardiovascular disease. In women, the vegan women did not do quite as well as pescatarian women, and they had a difficult time explaining the disconnect between the risk factors and the mortality, and we expect that more data will come out. So what is it that actually results in heart disease and mortality in terms of diet? And we continue to be informed about that, and I'll try to run through some of the data. One thing that is very clear, which was published a couple years ago from 2 prospective cohort studies, is that red meat consumption does increase cardiovascular disease as well as cancer mortality, and we'll talk a little bit about why that is. This study was very clear that processed red meat is actually worse than other forms of red meat. That was point A. Point B is that if you were going to try to substitute some sort of protein for it, that the best reduction in mortality was actually with nuts. That actually had a publication just a few weeks ago that was very similar, talking about nut consumption and the risk of mortality in the Physician's Health Study, showing about a 25% reduction in cardiovascular events and deaths if you did 5 servings a week, sort of going back to what was found in that portfolio diet. As I pulled up the reference off of PubMed to try to make a screen capture, had to notice on the side that there is a very robust amount of data on nuts, everything from stroke to cardiovascular disease, death, so it probably is a good recommendation. Leaving the issue of animal products versus non-animal products for a moment, have to mention sugar because this was actually published a few months ago, talking about cardiovascular or overall mortality and cardiovascular mortality in the United States, showing that sugar actually increased mortality as well. So we certainly agree with the new dietary guidelines to reduce the amount of sugar that we're eating. So anyway, back to the animal products. What is it about the animal products that seems to be so bad for us? One of the interesting sets of data was actually published a couple years ago talking about IGF-1, that this is a component that is in animal-based protein but not plant-based protein, published in Cell Metabolism. And the IGF-1, that's insulin growth factor, insulin-like growth factor 1, show that there was a relationship between the serum levels and mortality, and that comes from eating the high-protein diet. That it actually increased cancer, diabetes, and overall mortality. That if you were to switch it to vegetarian protein, you could actually be protective for the older adults particularly, and that was associated with a lower mortality. While we're looking at that data, there was actually a very interesting concept that came out of the Cleveland Clinic, Dr. Hazen's group, looking at the whole idea of phosphatidylcholine ingested here, and this got a lot of press. It was in the New England Journal of Medicine. They talked about the sources, dietary sources of phosphatidylcholine, that's meat, dairy, eggs, cheese, and that there are certain people who have microbiota in their GI tract that will be high responders in terms of taking the phosphatidylcholine and turning it into trimethylamine. And then there are people who have a high upregulation of enzyme transformation of trimethylamine into trimethylamine N oxide, which is a horrifically atherogenic compound resulting in increased strokes, heart attack, and death. And so there's a couple approaches. One would be to change out your gut flora, take antibiotics, put new gut flora in there, and the other one would be to develop an enzyme blocker that would stop this last pathway. And of course, my approach would say, just don't eat that stuff. But what actually happens is actually pretty clear that if you are in that high group because of the diet, the GI tract, or the hepatic enzyme metabolism, and you're in the upper quartile, you have an increased risk of myocardial infarction, stroke, and death. There actually is data on heart failure that is very similar to this, saying that if you have congestive heart failure, regardless of your BNP level, your TMAO level actually determines the 5-year mortality. And if you happen to be in the group with high BNP and high TMAO, you're in the worst group in terms of mortality. Leaving IGF-1 for a moment, how about phosphorus? And this is actually a very interesting story that plant-based diets don't have a lot of phosphorus, and the animal-based protein results in a lot of phosphorus intake. It turns out that pretty much everyone in the room, if your kidneys are working, has about the same phosphorus level regardless of what your phosphorus intake is. And that's because people who take in a lot of phosphorus will actually upregulate this enzyme, FGF23, fibroblast growth factor 23, increase urinary phosphorus excretion to maintain that normal serum level. But the problem is that it stimulates left ventricular hypertrophy and its resultant cardiovascular events, CKD, in terms of progression and mortality. If you look at the data with that, the highest quintile there has the biggest risk. And so how do you get rid of it? It's really dietary more than anything else. One other thing that's particularly relevant to our population here in Israel is the whole idea of heme iron. because I was fascinated by the comments yesterday that cardiovascular disease is lower here than cancer. And so I had to go back and put a couple of slides in about heme iron, because as most of you, maybe not all the Americans in the room would know, that kosher meat is where you pull all the blood out, if I understand that correctly, right? And so there would likely be less heme iron in that meat than other types, right? And it turns out that going back quite a number of years, there's this data on heme iron as opposed to non-heme iron and its association with myocardial infarction and mortality. There's more, and if that resulted in a high ferritin level, which is partly dietary and partly genetic, that results in a 2.2-fold increase in bad outcomes. That was in men, always looking for data in women and men, and there actually was a publication a few years ago that talked about the quintiles of heme iron intake in coronary heart disease in women, particularly with type 2 diabetes, and notice how premenopausal women have no problem with this, but after menopause, the amount of heme iron seems to correlate very well with the cardiovascular risk. How about our ACC-AHA guidelines? As I mentioned, we had sort of set the bar pretty high, and we're in active discussion about whether or not that's the way to continue. But for the prevention guidelines that came out last November, or November before last, we were really concerned about making sure that we had the best evidence available using large sample sizes, which eliminates a lot of the studies that I've been talking to you about. But there were a couple of studies that actually did get in, and that is the Mediterranean diet and the DASH diet, and a little bit of data on high versus low glycemic diets. To summarize it very quickly, the data from the Mediterranean diet, which actually didn't have the mortality outcome study for the Predimed study that was published in New England Journal of Medicine right after the guideline group had finished its deliberations. But it's very famous, particularly here, where fruits, whole grains, fatty fish, low in red meat, and that it did result in a decrease in blood pressure, but the strength of the evidence was low. It actually had no consistent effect, probably for the reasons we talked about, whether you have hyper responders in terms of cholesterol ingestion and other factors. That is, when you're doing a Mediterranean diet and you're swapping out hamburgers for fish, you may be reducing mortality, but you may not be reducing cholesterol intake. And so the strength of evidence was low on that. But when you look at the evidence that was published in New England Journal of Medicine in the Predimed trial, they'd actually showed a substantial reduction in cardiovascular events, that is acute myocardial infarction, stroke, and death from cardiovascular causes, and it didn't seem to matter whether you're doing nuts as part of the Mediterranean diet or extra virgin olive oil. Those two curves were superimposable. How about the DASH diet? This really was designed to increase mineral consumption, decrease saturated fat, to try to improve outcomes in terms of blood pressure, DASH standing for Dietary Approaches to Stop Hypertension. Two good randomized trials that were large enough to make our guidelines, and they did show substantial decreases in blood pressure, and the data did actually indicate a decrease in cholesterol, and that was by putting more vegetables and less emphasis on animal product intake. So to sort of start to sum up, there's a lot more that we couldn't go into in one session. You could sort of design an entire symposium around this. But there are a lot of health implications of the vegetarian diet, and if those of you who wanted to see more of it, I'd recommend Kate Marsh, who has spent a lot of time compiling this data. I'll go through very little bit of it, but one of them that's always concerned me after Paul Ritger's drawing our attention to C-reactive protein is the concept that vegetarian diets are anti-inflammatory, and probably the most recent high-profile example of this was Venus Williams, who developed Sjogren's syndrome 4 years ago, was off the tour, unable to play, and someone told her, go on a vegan diet, and she's back successfully playing without medication, reportedly. So that's interesting. Okay. I'm sure you're fascinated by this talk, but have no desire to hear the entire thing again. So I'm not sure how that happened, but we'll quickly get to where we were about to sum up. So I'll have to find out where that magic button was that goes to the top. And all right. So to summarize, the Kate Marsh data, the 5 prospective studies, these were mostly in Great Britain. She did come to the conclusion that there was substantially lower mortality from vegetarians, even in low ovo-lacto vegetarians and vegans, that the benefit was more apparent if you did this for at least 5 years and started at a younger age, and that if we try to look at what is it that increases the longevity in vegetarians, I've given you just a snippet of some of the things, such as heme iron, IGF-1, phosphate, but it also there may be other things such as saturated fat, potentially even cholesterol, particularly for the hyper-responders, and phosphatidylcholine. But on the other hand, it could be that the vegetarians have other things, such as increased fruits and nuts, and dietary fiber, antioxidants, etc., that are beneficial, and it's just an effect, a substitution effect. And we can't rule out, until you do randomized controlled trials in free-living populations, you can't rule out the fact that there are other healthy lifestyle choices, some dietary, such as less sugar, and some non-dietary, such as wearing seatbelts. So to conclude, I think there's enough data to say that the well-planned vegetarian diets are probably good for you in terms of prevention of many chronic diseases, particularly cardiovascular disease, that it may have some significant advantages for a variety of reasons over the meat-based diets. But widespread acceptance of this, I think, is going to require some large, well-designed, long-term randomized trials that are prospective in free-living populations. But in view of the weight of the evidence that's observational and the high-stakes cultural factors, they may be difficult to accomplish. So I'd like to end with one of my favorite quotes, that all truth passes through 3 stages. First, it's ridiculed. Second, it's violently opposed. And third, it's accepted as being self-evident. And I think we'll probably get there at some point in the next few decades. Thank you very much for your attention.
Thank you very much, Dr. Williams. I think we have time for one question if someone has a pressing question from the audience. If not, let me ask you, interventions, effectivity of intervention is really determined on compliance and the ability to use this intervention. How easy it is for someone that is a meat eater to become a vegan, and what do you think about compliance with being a vegan for someone that was a meat eater?
So my experience is actually very similar to Dean Ornish, and you saw those 3 groups. It wasn't that he wasn't trying in the non-compliant group. It's about 1/3 of the people are just refractory, 1/3 of the people do it partway, and 1/3 of the people are all in. And that seems to be very consistent. And in talking to Dean, he sort of morphed over the years to be more accepting of the fact that not everyone is going to do this, and gives the advice to try to meet people where they are and see, what can you do? And so it actually has sort of taken off in the United States that people will do meatless Mondays or some form of reducing the amount of meat intake, because they hear so much about the health effects. I think there's one in the corner. I don't know if you have time for a second one.
Hello, sir. Thank you for the lecture. I cannot resist it. Really, you mentioned a few times sugar and mortality, like in your lecture. Mortality is one thing. Significantly decreased quality of life is something which is associated with diet and obesity and so on. You mentioned sugar, but you did not mention the enormous amount of flour, white flour, and any type of flour that the Western world, and especially the American, use. The Chinese are 1.5 billion, and they do not have bread in their diet, and they are all thin. In the United States and the Western world, we all eat burekas and flour and pastas and breads and pizzas, and there are 1 billion fat people who suffer.
That's right.
And you do not take an action on this as the leading cardiology or cardiology institution in the world. You don't say a word about it, and you speak about red meat. How many steaks did I eat last month? 3.
Mm-hmm.
The rest of it is poultry. The rest of it is practically normal. And I feel okay, relatively. And now you're speaking about the ferritin, but you do not speak about the white elephants that you have in the middle of your living room. And this makes harm to an enormous amount of people. So do it.
So those are excellent comments, and my response is, first of all, we really do need more, even observational data on what we all believe is true, which is what you're saying. And it's interesting that you called it the white elephant, because it is white sugar, white rice, white potatoes, etc., that tend to have the high glycemic index and the high resultant insulin rush when you actually intake it. And so insulin, we know, is a growth factor that increases central obesity, increases insulin resistance, and is atherogenic. So I'm sure, while I'm sure that you're correct, it would be great to have a study that I could put up and say, yeah, this is the case. Thank you for the comment, though.